will be given by Dr. Khalid Hassan. Dr. Khalid Hassan will proceed for the next talk by Dr. Hassan Khalid. He will give us a talk about phacoemulsification in dense cataract with small pupil and pseudoexfoliation.
Good morning. How can I use this one? Okay. Pseudoexfoliation in Saudi Arabia is about 3.5%. There is no significant difference in the gender, which is regard to a study published in Saudi Medical Journal in January 2015 in Prince Sultan Military Medical City in Riyadh, Kingdom of Saudi Arabia. The implications for cataract surgery, there are two pathological manifestations for pseudoexfoliation, the zonular weakness and poor pupillary dilatation. Both have been identified as the most significant risk factor for the surgical complications. Small pupil in patients with pseudoexfoliation result from infiltration of the iris by the pseudoexfoliation material, which can lead to mechanical obstruction during mydriasis. Also, sometimes by the degeneration of the sphincter and dilator muscles in the iris, and the small pupil increase the risk for the iris trauma and small capsularitis, and later on a lot of complications like posterior capsular tear and nucleus posterior dropping the vitreous. Zonular weakness in patients with pseudoexfoliation results from infiltration of the pseudoexfoliation material in the fibrils in the origin of this zonulus and in its insertion, which can lead to instability of the crystalline lens during the cataract surgery, increase the risk of vitreous loss and other complications. It's very important to grading the severity of the zonulopathy in preparation for selecting the appropriate surgical approach and devices, which is helpful. There are 4 grades for the pseudoexfoliation result in zonulopathy. Grade 1, which is from 1 up to 2 clock hours of zonulopathy or dehiscence. Grade 2, from 2 up to 6 clock hours of zonular dehiscence without vitreous presentation. Grade 3, from 2 up to 6 clock hours of zonular dehiscence with vitreous presentation. Grade 4, more than 6 hours of zonular dehiscence. The ophthalmic viscosurgical devices in pseudoexfoliation cataract surgery, there are 2 types, dispersive viscoelastic material and cohesive. For dispersive, which is protect and coat the corneal endothelium during the surgery and can use to sequestration of areas of zonule dialysis and or vitreous prolapse to back it posteriorly. The cohesive viscoelastic material can maintain the anterior chamber, can use for viscodilatation of the small pupil, viscodissection to cleave the capsule cortical adhesion, expansion of the capsular bag during the IOL implantation or during the adjunctive devices implantation. It's very important to good preparation for the patient before starting pure phacoemulsification. By the adjunctive devices to address the smaller pupil preoperatively, it's very important to use maximum eye drop, maximum dilatation for the pupil by using the eye drops like like midriacil, like non-steroid anti-inflammatory drugs like midafrine, cyclogel also. Intraoperatively, there are a lot of adjunctive devices can use to dilate the pupil during the surgery of patient with pseudoexfoliation. We have to balance between the benefits of the pupil manipulation, what the surgeon prefer to use, what the risk of pupil manipulation. There is intraocular pupil expanding rings like Maillard rings, OSIS rings. There are also iris hooks to dilate the pupil. Sometimes sphenerectomy also can use to dilate the pupil. The adjunctive devices to address the zonular instability during the phacoemulsification in patients with pseudoexfoliation, like standard capsular tissue ring, Sioni ring, Anderson ring, Ahmed segment, capsular subotic Ahmed segment. Selecting of this specific device is dependent on many factors, including the severity of the zonal loss or dehiscence, regarding to the capsular integrity, and regarding to underlying condition, if the condition is progressive or static zonulopathy. Selecting of the IOLs in patients with pseudoexfoliation depends on also patient factors regarding to the adequate capsular stability, zonular integrity, surgeon preference. Usually, I'd like to use the open haptic, slower unfolding acrylic square edge stereocapsular IOLs. Reduced trauma of one piece acrylic during unfolding is probably an advantage over 3 pieces designs. Accommodating multifocal aspheric IOLs should be avoided as this is a progressive condition. This is video. This is patient present with cataract and pseudoexfoliation with pupil about 3.5 up to 4 millimeter. I used Triban Blue to visualize the pseudoexfoliation in this patient. Then I use the Maillard ring to dilate the pupil. It can give me about 6 millimeter diameter. Then I start do the rexes, about 5 millimeter. Then doing the hydrodissection and hydrodelimitation. Always in those patients, I prefer to use viscoelastic to do viscodissection to separate the cortex from the nucleus, like here. Then always also I prefer to test the rotation of the nucleus to be sure that the nucleus is separated from the epinucleus. I use horizontal chopping technique. The cataract was dense. Sometimes while removing like this type of cataract, I prefer also to use a repeated injection of dispersive viscoelastic material to protect the endothelium of the cornea while doing the surgery. After I finish, I remove the cortex. While removing the cortex, I notice that the posterior capsule is floating. I feel there is weak zonules in this time. So I decided to put the preloaded capsular tissue ring. Then I put the one piece acrylic foldable IOL, removing the Maillard Summary, pseudo-exfoliation presents challenges that must be adequately addressed with proper preoperative preparation, surgical care, and post-operative follow-up, with a comprehensive approach to a pre-operative and post-operative evaluation and treatment addressed in this review. I think satisfactory surgical results for the pseudo-exfoliation patient can be obtained